Good afternoon. I think we should start because it's a little past 1:15. So, good afternoon and welcome to this rapid fire cataract update session. So, we'll go one by one to all the speakers. So, please, first speaker, Dr. Anand Pagmer, please.
presbyopia using off-label presbyopic phakic diffractive intraocular lens. I don't have any financial interest in this. Recently, with the recent advances in cataract surgery has more or less become a refractive surgery. Even with the advances in the formerly biometric devices and other adjunct technologies, we still get many refractive post-operative surprises and unhappy patients. So to tackle them, we have many options like glasses, contact lenses, lens exchange surgery, corneal refractive surgery. Another option is piggyback lens where we place another IOL in a ciliary sulcus, and we have phakic IOLs, mostly used in a phakic patient to treat refractive errors. Use of these phakic IOLs in pseudophakic eyes with piggyback technique remains off-label use. In 2010, this Kojima first reported use of these phakic IOLs in pseudophakic eyes. There are another reports also. Notably, all these previous reports of legal phakic IOL was only used to correct post-operative distance residual error. But we used this presbyopic phakic IOL to correct post-cataract surgery residual pseudophakic presbyopia for the first time, represented as a unique aspect of this case. So we present a unique case where 48-year-old female patient, she was a beautician by profession, came with a history of undergoing cataract surgery elsewhere with the implantation of extended monofocal PCIL implantation done in both eyes 1 year back. Post-operatively, she complained of difficulty in unaided near vision, which affected her fine near work. So according to her previous record, she was post-operatively unaided 6.6 for distance and N12 for near vision. For that, she was prescribed 1.75 presbyopic glasses for near work. She also gave a history of undergoing another surgery 6 months back in the left eye, where plus 2.5 diopter 3-piece foldable lens was implanted in the ciliary sulcus as a piggyback to make her myopic. So she came to it to have a solution for her right eye so that she could do her near work without glasses, without affecting her distance emmetropic status. So on presentation, we examined her in visual acuity. In right eye, she was emmetropic for distance and unaided J5 for near. She required plus 2 diopter for near vision. In left eye, she was unaided 6 for distance and improved with -2 spherical to 6.6. And she was J2 for near vision. Her intraocular pressures were normal in both eyes. On slit-lamp examination, she was pseudophakic in both eyes. And left eye, there was a 3-piece foldable intraocular lens that was in the sulcus put as a piggyback lens. There was a capsular fibrosis in both eyes. Her fundoscopy, corneal topography, and specular microscopy was normal. So after examining her thoroughly, we had 4 options to treat her residual presbyopia in right eye. That was IOL exchange. As capsule was fibrous, it was risky, so we decided to avoid it. Then presbyopic LASIK. Because it was slightly less predictable, we also decided to avoid it. Then piggyback presbyopic IOL, it was not available locally, and off-label presbyopic phakic IOL. So we decided to go with it. It was a surgery was uneventful. We under HPMC we injected phakic IOL in anterior chamber. Then we tucked all the haptics under the iris. and then we removed HPMC thoroughly. So it was like a routine phakic IOL case. Post-operatively, we examined all the parameters on next day and every week for 4 weeks after surgery. At the follow-up, after 4 weeks surgery, operated eye was symmetric for distance, and that is 6 and near J1 for near. Her near vision was normal without need for reading glasses. Her slit lamp examination was normal, and anti-segment OCT showed good vaulting, that is 575 microns. So to conclude, our case demonstrates successful use of presbyopic phakic IOL as a piggyback IOL technique. But it's a unique case. We want further evaluation as its utility, and it could become an alternate option for ophthalmologists to offer patients with suboptimal outcomes after cataract surgery. These are few references. Thank you.
So it was an IPCL, multifocal ICL. Okay. Thank you. Next, second one. Question, yes.
What would be the formula to calculate the extra power?
Extra power means?
Basically an ACIOL, which we are using as a PCIOL.
But it's the phakic IOLs are usually using manifest refraction.
We are calculating and multiplying by 1.5 or using a particular formula?
No, just the manifest refraction, right? Manifest refraction. That's all. Same as a phakic lens.
Okay. Let's go to let's go to the second talk. Mike, please. Mike. Okay, thank you. This is on impact of pre-operative dry eye treatment with longer-acting liquefiable sodium on visual outcomes after cataract surgery, to be presented by Takeshi. There? No.
I'm here.
Okay. Oh, yeah, there. Sure. Please.
Hello, everyone. We investigated the impact of preoperative dry eye treatment with longer-acting dequasosodium on visual outcomes after cataract surgery with diffractive trifocal IOLs. The blurred vision is the number one cause of post-operative patient dissatisfaction in multifocal IOL implantation. And 30% of blurred vision is caused by decrease in contrast sensitivity, which is mainly caused by a dry eye. Therefore, we investigated whether perioperative dry eye treatment can improve post-operative visual outcome with diffractive trifocal IOL implantation. All patients were diagnosed with short TBUT type dry eye for both sides. Diffractive trifocal IOLs, Pump-Tix Alcon, were implanted. Perioperative dry eye treatment with long-acting dequasosodium or LADQS was performed one eye in each patient. Patient used LADQS 3 times daily for 4 weeks pre-operatively and 3 months post-operatively. Unlike artificial tears, LADQS has an ability to stimulate the secretion of both mucin and tears. These are tested parameters: tear film ability, tear film stability, ocular surface condition, and visual outcome were analyzed based on these parameters. Now results. This is a comparison of the impact of cataract surgery on tear film stability and ocular surface condition in each group. As you can see, all parameters significantly worsened post-operatively in each group. This is a comparison of degree of impact of cataract surgery on tear film stability and ocular surface condition between two groups. Again, regardless of peri-operative dry eye treatment, these parameters significantly worsened post-operatively. However, perioperative dry eye treatment significantly decrease the degree of impact on both tear film stability and ocular surface conditions. And this is a comparison of a post-operative corrected distant visual acuity between treatment group orange and the control group blue. Pre-operatively, there is no significant difference between two groups. However, post-operatively, treatment group is significantly better than the control group at each point. This is a comparison of contrast sensitivity 1 week post-operatively. Treatment group was significantly better than the control group at all spatial frequencies. This is 1 month post-operatively. Treatment group was still significantly better than the control group across a wide range of spatial frequencies. This is 3 months post-operatively. Significant difference remained at only higher spatial frequencies. According to previous studies, high level of functional vision, such as diffractive multifocal hours, visual acuity, and reading speeds, are adversely affected by the decrease in contrast sensitivity at higher spatial frequencies. As you can see in a graph, contrast sensitivity at higher spatial frequencies are more vulnerable to tear film instability. Our study indicated that perioperative dry eye treatment with LADQS significantly decreased the impact of cataract surgery on the contrast sensitivity at higher spatial frequencies. So these findings indicate that perioperative dry eye treatment with LADQS can be promising technique to improve this high level of functional visions. In conclusion, I would like to emphasize that perioperative dry eye treatment with LADQS can raise postoperative patient satisfaction level, especially in diffractive trifocal IOLs cases. Thank you for listening.
Any questions from the audience? Is Dr. Amir El Rosasi here? No? Okay. Next speaker is our co-moderator, Dr. Jiwan Titial. Comparative evaluation and morphological and visual outcomes using 2 laser capsulotomy devices.
Thank you so much. Good afternoon, friends. This is a study which we're going to compare 2 automated devices to do a capsulotomy. No financial disclosure from our side. You all know that from manual capsulotomy we have shifted to continuous curvilinear capsulorhexis, mainly because of phaco became so popular. Then now we have a laser capsulotomies, which can be a femtosecond laser, or it can be JAPTO, which is with a nitron ring, or you can have capsule laser with the recent application we have now also. This is our initial publication where we compared the femtosecond laser cataract surgery from the conventional surgery, where we could assess the capsulotomies and capsulorhexis and two. And we realized that with the femtosecond laser you have a better sizing as compared to a manual capsulorhexis. It was a significancy of 0.001. In terms of mean circulatory index, that means the circularity of capsulotomy or capsulorhexis were far better with the femtosecond laser device. That also was significant. And this proved that in wide cataracts, if you use femtosecond laser, it gave us a better centration and better circularity and better sizing of a capsule. And this is what we are going to compare with the capsule laser. I know that we have a subsequent speaker from Pune, Dr. Kelkar is going to talk about further also. So selective laser capsulotomy is, needs a very nice staining of anterior capsule with trypan blue dye. It absorbs the orange wavelength dye, which will be applicable to the stained capsule and makes the capsulotomy in less than 0.03 seconds. Because the type 4 collagen, which gets among versus collagen change, This is a study where I looked into, to compare the morphological features of femtosecond versus the selective laser capsulotomy in these patients in a prospective comparative study design done in RP Center, AIMS, New Delhi. 30 eyes, 15 each group were taken. The primary outcome for these cases was the shape and morphology of capsulotomy. The secondary outcome was intraoperative complications associated and visual acuity at 1 month after surgery also. This is a small video on how we do surgery, and this after we do a good staining of the capsule, you have to display with a proper viscoelastic. Normally we use sodium hyaluronate 1% in these cases. Proper focusing will give you a nice application laser. Like this is the good focusing is done. I think focusing one important criteria in these cases after fixation of globe and the entire laser is done. There's a retraction of a capsule because of coagulation happening in these cases. And the surgery is very, very simple. So this is the target size. We are planning for 5 millimeter target capsulotomy. In the results, we achieved in a post-op period, which was 4.08 millimeter capsulotomy. There's a slight shrinkage of capsular size happening after capsule laser. The second case, 5.3 target, and we achieved 4.48 millimeter capsulotomies. Therefore, we need to target slightly larger size of capsulotomy in these patients so to achieve good coverage of peripheral part of IOL in these cases also. In terms of looking into intended capsular opening size, there was around 0.6 diopter change from the effective, which we planned. The predictability was slightly less compared to a 0.1 in femtosecond laser. In the mean circularity index wise, it was almost equal in the two groups. The anterior capsulotomy extension was observed in 2 cases of femtosecond laser, none in SLC cases. There were complete capsulotomies in these cases. The visual outcomes were comparable in 2 groups of cases. So these are a subsequent outcome in these cases. There was a little difference between a femtosecond laser application as well as in white cataract cases with capsule laser. In femtosecond laser, you have a sudden egress of a fluid, while in a white cataract application, there is a slow egress of fluid happens. You can see after laser application, the fluid release is quite slow, and that prevents the extension happening in these cases. This is the advantage we have seen with the capsule laser device as such in these cases. To conclude, laser-assisted capsulotomies are well-centered, circular, and continuous in all both the femtosecond and capsule laser. Effectivity-wise, femtosecond laser seems to give a better predictable size, while the complication related to extension is very little with SLC. To summarize, as such, circularity index will be better, continuous is better because tissue bridges are lesser with SLC. And strength-wise, this is a study by Daya et al. They found that it is 1.5 times stronger than the CCC. And size-wise, you have to little titrate to get a better size in these cases. So this is a welcome addition to your cataract surgery as such, easy, less time-consuming, less expensive, and cost-effective also. Thank you.
Any questions from the audience?
I think this is a new thing, people will look for that. This is a microscope attached system. You don't require a large, big box of femtosecond laser, which is so costly and difficult to maintain also. If you have this, the most important part, that is a capsular opening, can be created easily, effectively, and better shaped also. So people might look for that. Yes?
Yes, ma'am.
Just now, it is, in India, it is, I think, taken care by My Healthscape people. They are providing this. As more people will go for this, the cost of this machine will also come down, because this is one important. Once you acquire the machine, there's not much of additional cost. You don't require PI in each case in these group of cases. That's also less costly for all of us and patients. It's in a microscope during surgery only. Yeah, it's attached to a microscope. Yes. Yes. Any microscope it can fit in. Yeah. Yeah. Like you have for your vitreoretinal biome fitting type of thing. I'm not sure. I'm not purchased yet. We had a machine as a demo for 1 year or so. And maybe, Jack can say later, because they have this machine, Kelker group have a long time, Complication, yes. If your focus is not accurate, you can have a skip areas. And if you by mistake stain the endothelium, because the dye is absorbed by these staining, so you should avoid staining coming to endothelium. Otherwise, it will form the ring in the endothelium also. So that is avoided. So staining has to be just anterior capsule. Recently, we have shifted to a painting of a capsule under the viscoelastic. So that gives a very smooth staining, and the staining should be there for longer time. It should be a thick staining. Yes, 100%. Viscoelastic is just to that's normal, like to flatten the anterior capsule.
I think you have to differentiate this with the femto, because in this system, the laser fires from the top and uses the stain and the energy of that cuts. In a femtosecond laser, the laser will fire bubbles from behind, from inside the lens capsule going outward. So this one is going down. The femtosecond laser is from inside the lens going up. So that's why when they fire, the milky, if it's a milky cataract, it doesn't obstruct the vision. Whereas when we use a femto, the bubbles percolate and the milky substance goes up. So that the application is different. This one is from the top down. The femto is from inside out.
Yes.
So that's the difference. That's why this one, that's why in the femto, sometimes when you fire that in a milky capsule like Harvey, sometimes boom, there's an explosion, because if it's a phacomorphic lens or something with high pressure, you sometimes can get an extension of the cut.
And also you have a high chance of skip areas in with the femtosecond laser, because your the configuration of capsule changes, or some areas will be blocked by this milky fluid.
Yeah.
It takes slightly more time than the capsule laser. Capsule laser is very fast. With a blink of thing, it happens. And it's just a coagulation. It's sort of argon laser. So it's very strong. It is supposed to be a 1.5 times stronger than the routine CCC, which is stronger than the femtosecond thing. And because of this burning, it's like a coagulation. The edges are little thicker, and it's very strong, rigid. So in that way, that prevents the extension. Also in the post-op period also, we hope that it will prevent the cellular migration towards the IOL surface also. Yeah. Okay, thank you.
Thank you very much. Next speaker, Dr. Rabia Nas, talking about the VVT IOL. Welcome, please.
Thank you. Good afternoon, everyone. Today I'll be presenting on the visual outcomes, quality of life, patient satisfaction after extended depth of focus IOL implant. I have no conflict of interest. Why should one prefer an extended depth of focus IOL? It is to gain an uninterrupted vision across all distances, to minimize the dependency on corrective eyewear, to minimize visual disturbances like glares and halos in low light conditions, and to gain a good night vision with unaffected contrast sensitivity. The advancement in the extended depth of focus IOL is that it stretches the light wavefront, giving a seamless vision across a continuous extended focal range which covers distance, intermediate, and near vision. The aim of my study is to study the visual outcomes, quality of life, and patient satisfaction after extended depth of focus IOL implantation. I had included all the patients above 18 years of age who had presented with clinically significant cataract, patients who had ocular comorbidities like pre-existing glaucoma, retinal diseases, corneal opacity, or amblyopia which could hamper the post-operative outcome were excluded. It was a single-center prospective interventional study conducted at National Institute of Ophthalmology, Pune between January 2022 to March 2024 on 340 eyes of 170 patients after a detailed comprehensive evaluation. The mean age of patients was around 61.6 years, and the gender distribution showed 61% male and 38% females. The outcome was assessed as binocular uncorrected visual acuity across distance, intermediate, and near, which revealed that nearly all the eyes showed 100% vision, that is 6/9 vision across distance and intermediate, and for near uncorrected visual acuity was 48.8% achieving N6 vision, 38% had achieved N8, 12.4% had achieved N10, and 0.6% had achieved N12 vision. The quality of life was indicated by giving a questionnaire to the patients 1 month post extended depth of focus IOL implant bilaterally. It was to judge their quality of life in day-to-day activities. So for the intermediate and distance work, 100% patients did not have little or no difficulty in doing activities like seeing traffic lights, seeing steps while walking, watching television, etc. While some patients, like 96% patients had difficulty while working on computers, and 92% patients had difficulty in riding two-wheeler or driving four-wheeler. Similarly, for the near vision, 100% patients had little or no difficulty in reading large fonts, writing checks or forms, texting on phone, whereas for small prints and reading newspapers, 88% patients had little or no difficulty. The patient satisfaction scores were particularly for seeing the glaze and halos complications post extended depth of focus IOL implantation. It showed that 100% patient had little or no difficulty complaining of any halos around bright light. 98% had little or no difficulty for glaze of oncoming, for complaining of glaze with the oncoming headlights, and 99% had no such difficulty of complaints like seeing shadows around objects. So in the end, I would like to conclude that after extended depth of focus IOL implantation, nearly all the patients had achieved an uncorrected distance and intermediate visual acuity of 6/9, with 87% patients achieving N8 or better vision for near. And with the quality of life, majority of the patients had little or no difficulty in day-to-day activities, and they all had a very high satisfaction score. The extended depth of focus IOL implant actually addresses the limitations of the traditional monofocal lens, as well as covers some of the drawbacks of the current multifocal lens, seeking functional vision across multiple distances with very less visual disturbances. Thank you.
Are there any questions?
This medicine claims to be the true EDOF, only true EDOF. Have you compared it with any other EDOF in the market?
No, ma'am, as such, no.
So, when you say true EDOF, there's like an ANSI standard where there are several lenses that were classified. So if the company chooses to submit, they will be rated. Now, there are many companies who also have the EDOF but don't choose to submit. So it's hard now to tell. Yeah. So, but then it's based on doctors' experience, what they like to use in their and country-to-country availability.
When you choose EDOF IOLs, is there any significance for the angle alpha and angle kappa?
Yes, ma'am, we do take that into account, that while doing the biometry, the IX and IY score should not be more than 0.6. Although this is much more important in taking a multifocal intraocular lens, but in extended depth of focus IOL also, we had taken patients who had as such no comorbidities, and also their biometry did not show any increase in alpha angle.
So angle alpha, angle kappa, usually you take that into account when choosing presbyopia correcting lenses. So not only EDOF, multifocal, so I think whatever standard you use for your multifocal will be a similar standard for your EDOF. That way you don't get into trouble and you don't risk, right? You think that, oh, this is risky, I use EDOF versus multifocal. No. If this is risky, just go to monofocal. That's it. Okay, thank you. Yes, yes.
Minimum pupil size would you like to operate on?
Pupil size, any comment? Any,
In my experience,
yeah.
what I found out is that when I use riveting, I use quite a few of them. The problem comes if they're at night when the pupil constricts with the light. The central part is for the rear, and that comes into focus. And in Indian eyes, over the years, we've seen that the pupil size reduces. So the concern here with this particular model is that long term, when the pupil size reduces, the blurring for distance would come. that is why the other IOs which are in the market is also cheaper. I'm not promoting or dispromoting any other thing. You have other IOs which do not have this central segment. They might be better in the long run.
Okay, thank you. Next speaker, please. Dr. Aditya Kelkar. Good afternoon, please.
Hello, good afternoon everyone. Thank you APAO for this opportunity. I'll be presenting my work on comparison of phacoemulsification with dexamethasone implant compared to an anti-VEGF injection, which is aflibercept in this case, in management of coexisting cataract and diabetic macular edema. So no financial interests. So very often you come across patients who have diabetic macular edema and cataract, and these patients do not wish to go to the operating room too often, and therefore there's always a good idea to combine cataract with injection therapy. So there are individual studies that compare anti-VEGF and steroid implants. However, there are not many comparative studies which have a combined phaco plus dexamethasone implant comparing it with the anti-VEGF therapy, and that's why we set out to do this retrospective analysis. So this is a study period between 2020 and 2023. We have 54 eyes that were treated with phaco and dexamethasone implant, and we had 47 eyes that were treated with aflibercept injection along with phacoemulsification for coexisting cataract and diabetic macular edema. The key assessments were visual acuity, anatomical outcomes at the time points, specifically at baseline, 1 month and 3 months respectively, and also the secondary outcomes in terms of importantly the intraocular pressure variations and the subgroup analysis based on presence and absence of hard exudate at the same time pre-existing treatment. So the results of the two groups were quite comparable. With the anti-VEGF group, we achieved a visual acuity gain from 1.02 to 0.49 logmar, very similar to what we achieved in dexamethasone implant, slightly better though, was from 0.93 to 0.38 logmar. We also tried to compare it with the treatment naive group. I'm sorry about calling this as a recalcitrant. I would rather call it as a recurrent diabetic macular edema, where these patients were previously treated, and we realized that the results are quite similar in both the groups when it comes to treatment naive or those patients who have had treatments in the past. At 3 months, the central macular thickness reduction was quite similar again, 293 microns with dexamethasone implant compared to anti-VEGF group, although dexamethasone implant does a little bit better than the anti-VEGF group. Similar results once again when it comes to central macular thickness for treatment naive group as well as those patients who had a recurrent diabetic macular edema. Post-operative intraocular pressure elevation as expected was more in the dexamethasone implant group, but it was only 14%, which was well managed with anti-glaucoma medication as compared to only 2 eyes in anti-VEGF group. No significant difference of intraocular pressure outcomes at 3 months that were observed. What we would like to reiterate is that most of these patients who had dexamethasone implant at the time of end of the study protocol of 3 months, none of these patients required a re-injection as compared to about 30% of the patients at the end of 3 months as expected were due for another injection. So combined phacoemulsification with intravitreal therapy, either steroid or anti-VEGF, especially the longer acting like aflibercept, is a very effective treatment modality to address the two comorbid conditions at the same time. The surgery-induced inflammation can be exacerbated because of and causing macular edema to worsen, and therefore a steroid therapy probably has a better role compared to the anti-VEGF therapy. Both dexamethasone and anti-VEGF significantly improved the visual acuity and central macular thickness at 3 months, and dexamethasone implant showed greater anatomical improvement compared to the anti-VEGF group. However, the visual acuity improvements were quite similar, and as expected, the dexamethasone implant group had a transient IOP elevation which was normalized at the end of 3 months. The limitations of the study include the retrospective design, non-randomized, and of course the shorter follow-up time. Thank you.
Thank you. Any questions?
Yeah, a very nice paper, Aditya. Because the half-life of the dexamethasone implant and the anti-VEGF drugs are different, Do you think there's an advantage in injecting these medicines prior to the surgery? And if so, how soon before, how long after the injection would you do the surgery?
Yeah, as a standard protocol, we would like that the patients have the macular pathology stabilized prior to undergoing cataract surgery. But many of these patients have logistic issues where they don't want to come in for injections and surgery separately. So it's a good idea probably to combine these two procedures at one go.
Any more comments or questions? Thank you.
Thanks.
Thank you. Next speaker, Dr. David Beckers, please, on the MF15 lens.
I'll put these up a little bit. That might be useful. So thank you very much for the kind introduction. This is supposed to be an update session, and to give you an update on the common disbelief that you should only keep the premium IOL to patients who don't have any comorbidities. We just did a little analysis I want to show you. So I asked myself the important questions of life, which is which lens for which patient. That plays probably the most important role in our everyday life. And we just probably have too many to choose from. And which one is the best is just always a difficult answer. And the same way you just mentioned it, if you're in doubt, well, I don't know, just put a monofocal in and then see how it goes. And we think, well, there's a better way to do it than just to put a monofocal in. Because there are ways when there are alternatives and when premium can become a standard. And for us in our clinic, the MF15 is pretty much the standard IOL we use in every single patient we have. So it's an EDOF IOL, which works with a refractive design, is aspheric, has some plate haptics and a copolymer, which consists of a hydrophilic core and a hydrophobic surface. Therefore, it expands inside the eye very easily, very smooth and quickly, and it even fits through in 1.8 millimeter incision size, even though routinely we use 2.2. So if you think premium IOLs are only for perfect eyes, we want you to think again, because what about the patients we all have, and probably we have more of, which are these patients with glaucoma, age-related macular degeneration, epiretinal membranes, or also Fuchs endothelial dystrophy. These patients are actually the ones we see every single day, and we think to just put a monofocal into these patients doesn't give them what they could be having. So we think you should go a different way. Therefore, we did a defocus analysis of our large cohort of MF15 patients. We are currently working on that 1 year post-op results. Currently evolving, we are up to almost 150 eyes so far. 1 year post-op, and we did a subgroup analysis of all those patients I just showed you having glaucoma, age-related macular degeneration. As you can tell, you achieve an uncorrected visual acuity of 0.6 up to 1.5 diopters near addition. And therefore, not only perfect eyes, but also those eyes benefit a lot from these lenses. Especially, we have to admit, in this subgroup analysis, there are even the worst patients you could imagine. So we have some wet AMD patients in there as well, because we don't even counsel our patients whether we put this lens in or not. So the right question remains, which optic for which patient, not which lens. And therefore, this refractive segmental design gives us the advantage that it has such a high light transmission. If you compare it, for example, to a trifocal, you have just a light transmission which is superb of 93 to 95%, which gives you a very good contrast vision. And also, if you compare it to other lenses within a halo and glare simulator to look at photopic phenomena, you can see even compared to a monofocal aspheric IOL, the vision is not worse than in these patients. So just to conclude, for us, there is no disadvantage in uncorrected distance visual acuity. So we would hate to give a patient like 6/9 for distance. So all our patients routinely get up to 6/6. We have equal contrast sensitivity compared to a monofocal IOL. They get a near addition of 1.5 diopters. And as we were talking about angle alpha, sorry, just wait for the beep. All right, and it's the only asymmetrical refractive design, and therefore you can perform an alignment to the visual axis. No other rotational symmetric IOL can do that. So if you have a large angle kappa, it doesn't matter in these patients. You don't have to look at it because you just put the visual axis through the distant segment. And therefore, next time you think, well, which lens do I want to put in? Well, just put an MF15 in, and then you should be good to go. Thank you very much for your attention.
Any questions from the audience? So the MF15 is part of the, you have many mechanisms for EDOF. So the MF15, the vivity is like, they call it wavefront. The MF15 is like a refractive bifocal segment. You have spherical aberration, you have pinhole. So it's one of those mechanisms which allow a lens to give extended depth of field.
If I would like to comment on that, for me, it's one of three. So if you break it down, you have those pinhole lenses, which are a great niche product for irregular corneas, for other aberrations. And then you have spherical aberrations, and that concludes pretty much everything. If you look at the data sheet of every single other company producing, there are those companies which openly say, okay, these are spherical IOLs, EDOF IOLs, which use spherical aberrations, and I love that they do that, but to call it an X wave, and then if you look at it, oh, we just call it fourth and sixth, generation aberration, that's pretty much the same as spherical aberration per definition. So just the companies try to sell us something we try not to understand. So therefore, I would say the main group of EDOF IOL are spherical EDOF IOLs which use spherical aberration, and then in the third group we have these lenses which just use the segmental area, and therefore we just prefer it over the others on a daily basis.
Any more questions, comments? Okay, thank you very much.
Thank you.
Okay, Dr. Chow, Chen Chow from talking about the vivity and vivity toric. Welcome.
Good afternoon, ladies and gentlemen. My topic is about vivity and vivity toric IOL in Taiwan. It's results and analysis. We are from Taiwan Nobel Eye Clinic. Our study is supported by Alcon. The Microsoft IQ Vivity is the first non-diffractive wavefront shaping EDOF, designed EDOF IOL in the world. The aim of the study is to evaluate the quality of vision after bilateral vivity or vivity toric EDOF IOL implantation in cataract patients in Taiwan. And this is the first large-scale prospective study on the outcomes of Chinese individuals using vivity. Our study is prospective single-armed and held in 8 Nobel Eye Clinic group in Taiwan by different surgeons. And we selected the patients without previous corneal refractive surgery who received bilateral and uneventful implantation of vivity IOLs. The target was set at emmetropia or minimal vision. There are 2 visual parameters were assessed, include visual acuity and visual quality. Visual acuity measurement include binocular UDVA, CDVA, binocular UIVA, DCIVA, and binocular UMVA and DCMVA. The visual quality measurement include the questionnaire for visual disturbance, QVID, the intraocular lens satisfaction, IOL SAT questionnaire, and international reading speed test, IRES at intermediate distance. The visual acuity is measured at post-op pre-op and post-op 1 week, 1 month, and 3 months. For visual quality, it's measured pre-op and post-op 3 months. There were 84 patients included in our study. At 3 months, in the emmetropia group, there are 39 patients. And in the minimal vision group, there are 40 patients at 3 months. This is the baseline factors. There are 84 patients, with most of them are non-toric IOL implantation. The mean age was 61 years old, and then with female predominant. You can see that visual acuity results at 3 months. For CDVA, there are 67% of patients with 20/20 or better. For DCIVA, there are 77% with 20/25 or better. For DCMVA, there are 75% with 20/30 or better. We also compare the emetropia group and micromolar vision group about their visual acuity outcomes. There are no statistics significant at 3 months. And for the result of QVIT, the red bar show the mild to severe visual disturbance. There are 7 kinds of parameters measured in this QVIT questionnaire. We can see that for the grade 2 to 4, there's only 32% of starburst and 20% of halo and glare. For haze and blur, there was less than 20%. AIOS-80 is the percentage of subjects rarely or never need reading glasses. For far distance, there are 95%, they are spectacle independent. And for intermediate, there was 97%, and for near is 75%. The reading speed at intermediate, compared with pre-op, the post-op 3 months, the average reading speed is improved. And our research finding indicate that patients have good distance vision, decent intermediate vision, and acceptable near vision. The AIOS-80 reveals most patients are well adapted without glasses under various light conditions and different distance. The QVIT show mild dysphotopsia with starburst may be the only noticeable visual disturbance. As one of the first research testing reading speed by IRIS, it showed patients have great improvement post-op in intermediate distance reading. Thank you.
Any questions from the audience? What's your target refraction for the mini monovision?
The non-dominant eye, mini monovision is 0.5.
0.5.
Yes.
And this is your recommendation, or you want more minus for better reading, or this enough?
Actually, while patient want more, they will choose like maybe one diopters for the non-dominant eye. But for these patients, they cannot be included in our study.
Yeah. Yes. Okay. Any questions? Okay, thank you. I think I'm next. Good afternoon. So I'm here to present our prospective study on small aperture IOLs in previous refractive patients. So as Dr. Becker said, there are 3 mechanisms for EDOF. Number 1, refractive bifocal segment. Number 2, change the spherical aberration in the middle. And number 3, pinhole. So this is the pinhole optics. So I'm a consultant for both AkiFocus and investigator for Bosch and Lomb, which bought the AkiFocus company, which makes this small aperture IOL. So there's an increased need for a versatile IOL, just like what we want. We want one IOL for all, but unfortunately, that's not possible. So in our case, we use it on normal corneas. We have patients who had a previous corneal inlay. So if you remember the history of presbyopia correction, there was a time in the early 2010, 2012 that people were putting corneal inlays. And then there are patients now who had previous RK, LASIK. So what do we do with these patients? So these patients have corneal aberration. So as Dr. Becker's population is those we have compromised in the posterior segment. These are the retina, the glaucoma. This one is the compromise is in the cornea. So those are 2 different usages for 2 different populations. So we cannot use the pinhole on the compromised retina because it's pinhole. If the defect is in the center, no use. Whereas you cannot use the segmental if there's a compromised cornea because you will get more aberration. So it's two different population targets. So the IC8, it's called an Apthera IOL, and it has two main functions. Number one is the pinhole effect masks the aberrations of the cornea. So the pinhole negates most of the aberrations of the cornea, and the second effect is presbyopia correction by EDOF. So now we have patients who had post-LASIK, post-RK, that's fine. You see all of that. But those of us who have put inlays in the cornea 10 years, 15 years later, now they have cataract. What do we do with them? Option one, just do the cataract surgery, leave the inlay in the eye, and put a monofocal IOL. Option two, which is in this study, we remove the inlay, wait 3 months for corneal stability, measure the IOL power, and then do the cataract surgery and put the IC8 pinhole inlay. So from last count, there were 30,000 eyes with this AccuFocus corneal inlay. So they will be coming, some of them will come into you. So what do we do with these patients? So this is an RKI. We put, this is what it looks like. It looks like your new smaller pupil behind the pupil. So this is what it looks like undilated, and this is what it looks like dilated. So initially, we did a scleral tunnel because we didn't want to fold the IOL, but now we have injectors. So these two groups, one is the post-refractive, which is previous RK and LASIK. Two is post-inlay. So refractive targeting was minus 0.75 diopters. So that's the refractive target of the IC8 small aperture, not plano. Okay? So we did the study, 12 months follow-up on them. And as you can see here on the left is uncorrected visual acuity of the post-refractive eyes. Because of the pinhole effect, distance vision, the blue is the IC8, 0.4, 0.04, 0.09. So 2025, 2025, 2025. Distance correction is about 2020, 2025, 2025. So that's the usual result as long as you're on target. So our MRSE on the bottom right is about minus 0.55 diopters. So be more minus. If you want to use this lens, it's better to be more minus than plus. You see that the focus curve is wide and equal in both sides. All other EDOFs are one side steep and one side like that. This is equal because it's pinhole. So it's an equal like a symmetrical Mount Fuji. Okay? Mesopic, everybody worries that it's dark. It's dark. It's dark for patients. But on-label approach is one eye, non-dominant eye. The only problem you will have is post-RK because two eyes have RK. So now you need two eyes. But all the rest is one eye, the non-dominant eye, and the dominant eye use your standard monofocal or EDOF lens. So in terms of post-inlay, same results, 2025, 2025, and 2030 uncorrected. That's the most common outcomes in these small aperture eyes. And of course, binocular, the distance is better because the other eye has a monofocal for distance. Again, the focus curve is it looks flat because it's small aperture, no? 2.5 diopters. It's not J1. That's why it's EDOF because the optics cannot give you J1. But again, with mesopic contrast sensitivity, there is a 2 decibel drop in contrast sensitivity measured by visual field. So yes, it is slightly darker, but not too obvious. So visual symptoms, because it's pinhole, there's not much glare because the pinhole filters glare, filters aberrations, but there is some halo effect which some patients notice when driving at night. So in terms of 1-year outcomes, so far so good. Most patients, almost all patients have this continuous range of vision like EDOF, increased depth of focus, monofocal-like contrast sensitivity, and low levels of visual disturbance, but it is something for you to use in your aberrated corneas and maybe in your normal corneas as well. So it's one of the options that we have now, the small aperture IOL. Thank you. Sorry, are there questions? Sorry. Yes, Harms. There is no minimum pupil size. There is a minimum dilated pupil size. You need to be able to dilate your pupil at least 6 millimeters before you use it. Not a small pupil, but a big pupil, because you need to check the retina after. And when you dilate, we check outside the mask. So the black mask is 3.4 millimeters. So you need to be able to check the retina. It's for the retina checking. But the small aperture inside is 1.3. So it's like a small pupil. Any other questions? So very useful. So now you have representation, and one more from the next speaker, representation of all the EDOFs in the market, which is a good, this makes this session standing room. Please, Abby. So Dr. Maria Isabella De Guia will present her results on the Rainer EMV.
No. Sorry. Okay, good afternoon, everyone. I am Dr. De Guia from the Philippines, and I will be discussing the visual performance of the enhanced monofocal intraocular ray 1 EMV lens after cataract surgery. So at the time of this research conduction and submission, I had no financial interests to disclose. However, at this current time, I am providing consultancy services to Rainer Intraocular Lenses Limited. I performed this research with my co-investigators, Dr. Caparas and Dr. Duyonco, and the purpose of this study, done at the Medical City, Metro Manila, Philippines, was to evaluate the long-term visual outcomes after bilateral implantation of the enhanced monofocal IOL Ray 1 EMV. So for our study, we had 15 patients, total of 30 eyes, bilateral, who underwent phacoemulsification for cataract surgery, and they were implanted with the Ray 1 EMV. Patients were tested at 2 to 8 days, that was at T1, and 30 to 45 days from surgery. And what we measured was our monocular and binocular uncorrected and distance-corrected visual acuity at a distance of 4 meters, intermediate at 80 and 63 centimeters, and near vision at 40 centimeters. In addition, binocular defocus, contrast sensitivity, glares and halos, and light spectacle independence via a questionnaire were tested. So results showed that the mean spherical refraction was about minus 0.12 diopters and minus 0.15 diopters at T2, which is hardly significant. Our mean binocular UIVA at 80 and 63 centimeters and UNVA at T1 were minus 0.13, 0.37, 0.29, and 0.43 logmar respectively, while our mean binocular CDVA for T2 was at 0.17, that of our 80 centimeters was 0.39, 63 centimeters was 0.33, and our near at 40 centimeters was only 0.3. Okay. For our far and near mean monocular contrast sensitivity at T1, that was at 1.38 log CS and 1.42, and at T2 was at 1.36 and 1.33, while our mean binocular contrast sensitivity was at 1.55 and 1.56 respectively. We did notice though that 100% and 86% subjects experienced H1 halos and G1 glares at the first consult. However, these were at extremely low levels and were noted to be significantly less prominent at the second follow-up and significantly decreased with the dry eye treatment, which we saw. So during our first consult, we were actually surprised at how high it was, but within just 2 months later, we saw that it was already significantly lower. So implantation with enhanced monofocal Ray 1 EMV provided excellent post-op VA for distance, very good vision for near, which if you compare this actually to other studies that were done using this EMV lens with Caucasian eyes, it's actually quite significant. So only a fraction of our patients that we saw needed presbyopia correcting lenses post-surgery. And we still, even with excellent and very good near distance, had a very good intermediate. And these features, along with its outstanding contrast sensitivity, very low levels of glares and halo phenomena, yielded a high degree of patient satisfaction after surgery. So it has actually been my choice of lens since using it, and we are currently working on it, and even longer term studies of up to 1 year. And we hope to present those 1 year studies results for you for next year. Thank you for your attention.
Very nice, Abby. Any questions? Yes, sir. Ah, yes, sir. Can you give the microphone to sir?
I've implanted around
Yes.
250 lenses in the last year, and all of these patients, they require plus 1.5 diopter of spherical correction for near vision.
Oh, so we've been, may I ask your target for the target of your lens?
See, the distance was zero. They were
Targeting for plano. So normally what we do is we do target for plano. However, we notice that the vision of the patients actually ends up maybe a little bit of a minus, plus 25. So when we target for plus 25, they come up to more plano. We find that maybe with our Asian eyes, it could present a difference. It was something that we were actually discussing earlier, that with most of our patients, only 25% of them have needed at this point presbyopia correcting lenses. Could be also contributed to dry eye treatment because we treat the dryness afterwards very vigorously after the treatment of, after giving post-op anti-inflammatory and anti-infective medications. So it could be something that we want to look into also in the future. Thank you.
The tricky part about all of this EDOF, monofocal plus, is actually refracting them well. If you have a good opto or yourself, you need to refract them well. So you know what, if you're achieving target or you're a little bit plus or a little bit minus. So during the early times when people didn't do push plus, we used to do a technique called midpoint refraction, wherein you put in plus and you put minus and then you report the midpoint. That way you kind of have an idea what your range of 2020 is. Maybe your 2020 between plus 0.5 and minus 0.5, therefore your midpoint refraction is 0. So it's very tricky to you perform better like this if you're a little bit biased towards the minus, right? It helps. That's why mini monovision is always an option. But when we evaluate, it's hard if you don't refract them, and over time sometimes they change refraction. So each doctor will have their own experience with a lens, but the results can vary because of that. But so far, I think there's no doubt that most of the EDOFs, they really the EDOFs are told are said EDOFs because they will be expected to be good at far and intermediate at the minimum, right? That's our goal of, and then we accept and we make the patients accept that they need reading glasses. I think that's on the safe side. We expect, and that's why they label EDOF, or else they label something else, like a full range of vision or something. So, but first, a target to target differences can affect. No? Any more? Yes, ma'am.
Refer this IOL for a driver by hobby or a driver by job? Are they going to have glare and halos?
So far, based on our results, it doesn't look that it's quite significant.
These IOLs for drivers?
We have used this IOL for people who drive at night. Thank you.
Very good, Abby. Thank
Thank
you.
you.
Thank you.
Thank you.
Great talk. So, we're done with first 10. There was one author missing, Dr. Amer El Rosasi. Is he or she here? No? Okay. Please. Ma'am, Dr. Jai Kalkar. Good afternoon, and please.
Good afternoon, everyone. So my talk is on use of selective laser capsulotomy, or the capsule laser, for white mature cataracts, our experience. I have no conflicts of interest. The purpose of this study was to report the initial experience, specifically intended to be used for mature cataracts. So it's a prospective, non-comparative open-label study. We looked at 30 eyes of 30 adult patients who had a good pupillary dilatation of more than 6 millimeters. The mean age of patients was 64.6 years, and the exclusion criteria were patients with known pre-existing ocular pathologies like retinal pathologies, glaucoma, subluxated traumatic cataracts, complicated cataracts, and zonulopathies. I'm sorry, this is not moving further. Yeah. So the outcome measures were the efficacy parameters were the size and the continuity of the capsulotomy edge at the end of the surgery, the surgical time taken for SLC and IOL centration in the back 4 weeks after the surgery. Other observations were post-operative endothelial cell count, IOP, 360-degree capsulotomy coverage of the IOL, centration of capsulotomy, and any events such as laser damage of the corneal epithelium, stromal marks, and or iris damage. I'll quickly take you through this video. You have to stain the capsule with the specially provided capsule blue dye. You have to wait for a minute, and the staining should be adequate because it is the blue color which is going to attract the orange laser. Give a thorough wash so that the staining of the endothelium, staining of the posterior lip of the incision does not happen, because the laser will act exactly where the part which is stained. You need a good anterior chamber fill of the viscoelastic, a high density viscoelastic. This is the centration of the beam. The beauty is that in mature cataracts, you can either look at the central trypan landmark or even like the Purkinje images and center it around the Purkinje image. So that's all the time that it takes, about 0.3 seconds for the capsulotomy to be completed, and more often than not, you will get a free floating edge. The cataract proceeds like usual, and then you can implant the lens. And you can see that the IOL is very well centered, and it has a good 360-degree overlap with the capsule. So the results, all patients completed the 3-month follow-up, and post-operatively, the mean best-corrected visual acuity on day 1 was 0.3 log marks, which improved to 0.03 log marks at 1 week follow-up and remained so till 3 months. The mean post-operative IOP was 15, and at 1 week it was 14, and there were no major IOP spikes noted. The mean perioperative endothelial cell count was 2400 cells, which reduced to about 2200, showing an 8% reduction. The total surgical time was 13 minutes, give and take 1 and 2 minutes, with the time for capsulotomy after completion of the main incision being 3 minutes. The TCL, or the trypan central landmark, was visible in all eyes, and this is often useful or required when the patient has a white mature cataract and cannot focus at the microscope light, which is so essential for the centration, because we need a visual center rather than a pupillary center. And neither of the two surgeons who operated experienced any difficulty in removing the loose anterior capsulotomy cap, and the intraoperative size of the capsulotomy was uniform and as intended in all eyes, and the edges were smooth. None experienced runoff, but however, because of the stain of the anterior lip of the incision, the dye could not, the laser could not reach up to the capsulotomy, and therefore we ended up getting a tag. All cases had a well-centered IOL with a stable refraction, and this is the photo taken which shows the refraction at the end of 3 months of the IOL pair. This is the anterior segment OCT, which shows that the capsulotomy range remained from 5 to 5.5 millimeters as was planned, even at 3 months. So capsule laser is a device which is attached to the surgical microscope, and it's a solid state laser beam at 590 nanometers, and it's absorbed by the trypan blue dye that has stained the anterior capsule, and it causes the disruption of the type 4 collagen of the anterior capsule, changing it to an amorphous collagen. The SLC fracture strength, which is a measure of its strength and distensibility, is 1.5 times higher as compared to that of a manual, and in turn 1.3 times stronger than the femtosecond capsulotomy. The capsular edge of the SLC on scanning also showed that it has a rolled over margin, and that prevents the capsule from running off or causing tears. And so far, no studies indented specifically for white mature cataracts have been done, to the best of our knowledge. So this is how the machine, the unit looks like, and you can attach it to a microscope. And this is how the rolled over edge looks like, and when it's converted into an amorphous collagen. Drawbacks, just to name, it requires a well dilated pupil. The anterior chamber also should be well formed, and it can be achieved by sodium hyaluronate. If the cornea is not clear, then the laser will not necessarily achieve the desired complete capsulotomy, just like a femto would not. So to conclude, SLC is safe, effective, and provides a precisely sized, circular, centered, and minimally traumatic capsulotomy. It works well in challenging cases like the mature white cataracts. But of course, further research and larger samples in similar design will help us reinforce these findings. Thank you.
Thank you. Okay. Maybe we should go on to the next talk because there's a next session later. Thank you.
Yeah, thank you.
Next speaker is Dr. Valeria Mansova. Please.
Hello. My name is Alexandra Proshka, and I'm a co-author of this work. Unfortunately, Valeria Mansova isn't here today, so I will be the presenting author. Thank you. And I want to present our research work about cataract extraction in patients with keratoprosthesis. Nowadays, it is widely known that cataract is a common condition accompanied by corneal glaucoma in patients who underwent keratoprosthesis, and for patients who is going to undergo this operation. So the objective of our work is to evaluate the differentiated approach to surgical treatment of patients with vascular glaucoma and cataract. And this approach, this surgical treatment includes cataract extraction at various stages of keratoprosthesis implantation. To make it a little bit clear, in Russia, we perform keratoprosthesis implantation in 2 stages. The first stage involves intralameral plate implantation, and the second stage involves optical cylinder implantation. So our surgical approach is going to be different because of different corneal glaucoma thickness. If it is less than 500 micrometers, then we perform corneal prosthetic complex transplantation simultaneously with cataract extraction. And if it is more than 500 micrometers, then we perform cataract extraction during the second stage or in the long-term postoperative period. And there are some complicated cases when we perform intracapsular or extracapsular extraction during different stages of keratoprosthesis implantation. So our study enrolled 30 patients, 30 eyes, who underwent these manipulations, and we divided them into 3 groups. The first group included eyes of patients who underwent cataract extraction simultaneously with corneal prosthetic complex transplantation. The second group involved eyes of the patients who underwent cataract extraction during the second stage. And the third group included eyes of patients who underwent cataract extraction in the long-term postoperative period after keratoprosthesis implantation. And it was made by doing fecal emulsification or intracapsular extraction. During pre-operational diagnostics, we paid attention to the corneal thickness and to the extent of lens ligamentous failure. So in group 1, we performed so-called open sky cataract extraction. And after that, we transplanted corneal prosthetic complex. And it is important that we didn't implant any intraocular lens because there are a lot of risks for postoperative complications in this case. And we just implanted aphakic optical cylinder as the second stage. In the group 2, we performed cataract extraction during the second stage of the keratoprosthesis before implanting the optical cylinder. It is also extracapsular, but the difficulty is that we have limited visualization, and sometimes lens masses are not totally removed. So there were some patients that we needed to who needed to undergo the second operation in the early postoperative period, but it didn't affect the outcomes. And the visual acuity was really high. And the third group, there were 4 patients who underwent intracapsular cataract extraction, but it was really traumatic because of the big cut. And only one case when we performed a fake emulsification, but it was really dangerous, and we decided not to do it again because of the high risks of intraoperative complications, and we don't recommend it to perform, to be honest. So there were some complications in each group, in post-op and intraoperative and postoperative complications. And here you can see the results of our research. If we compare it with preoperative ones, the visual acuity increased significantly in each group. So in conclusion, I would like to say that cataract extraction in patients with keratoprosthesis is really technical, difficult operation. And of course, the surgeon needs high surgical skills for doing it, but we hope that our research and outcomes will help to deal with this problem successfully for all of us. Thank you.
Thank you very much. Thank you very much. Maybe we go on to the next speaker, please. Dr. Humaira Bakmid. Dr. Bakmid, am I saying the name correctly? No? Okay. Next speaker is Dr. Shruti Ramesh, please.
All right, good afternoon and all. So I think I'm kind of presenting a bit of a controversial topic. We always have a debate whether to do an immediate sequential bilateral cataract surgery. So this was one of a study we did comparing both phacoemulsification and manual SICS outcomes. So basically to evaluate whether it's safe and whether the outcomes are worth doing an ISBSC in terms of phaco and SICS. So it was a retrospective study. We collected the data for the past 30 months. It was done in a tertiary eye care center. The inclusion, basically anyone with a visually significant cataract and aged over 40 years. But the exclusion criteria, we made sure we were stringent about it because we did not want any complicated cataracts, any extreme axial lens, which can lead to further complications later on in terms of retinal detachments or corneal pathologies causing decompensations. So we made sure we also did a good specular count, and any less than 1,500 cells were not included in the study. And patients also requiring combined procedures were not included. So what we realized was if we had good validation guidelines for biometry and good intraoperative planning, it was very safe to go ahead with the procedure. So patients with who were able to do optical biometry, we did with LensStar, and the formula we used was the Barrett Universal 2. But for patients with dense cataracts, we went ahead with the immersion biometry, a manual keratometry, and the SRKT formula was used. And the intraoperative protocol was each eye was basically looked at as like a different patient. So we made sure that the autoclaving was of a different batch and different surgeons performed for each eye. And all patients had intracameral antibiotics provided. So it was done by 3 surgeons overall, and we documented all the intraoperative, postoperative complications and the outcomes. So a total of 1,306 eyes were included in the study, and the distribution between both groups was almost more or less equal, with phaco having 56%. So what we did with the outcome was we did for a 1 week and a 1 month analysis, and what we realized was the spherical equivalent. We kept that good spherical equivalent outcome was plus or minus 0.5 diopters, and almost 95 to 96% of them achieved that at 1 week. And it was similar again with the manual SICS as well as the phacoemulsification. Same for 1 month, if you see that it did not change much and it remained stable. So the difference between the 2 groups was not much significant in terms of the spherical equivalent. Target refraction was achieved. And the complication rate, again, amongst both the groups. So what we looked at was the PCR striate keratopathy, which was, again, just intermittent, and post-op iritis, cystoid macular edema, and iris prolapse. And between both groups, more or less equal. And the numbers were also, again, within the limited range. So in terms of vision-threatening complications, I know PCR is something that we all look at as the dreaded one in cataract. So what we kept as a rule was if the first eye had a PCR, we did not go ahead with the second eye surgery because, again, risk of end-off increases. And in the number of patients that we had the PCR, 2 did not have vitreous disturbance, so we placed the IOL in the bag, but 3 had vitreous disturbance. So anterior vitrectomy was done, and IOL, 3-piece IOL was placed in the sulcus. 1 patient did have bilateral CME. They were a known diabetic, but again, it was managed just with topical steroids and NSAIDs. And a few people also had striate keratopathy, again resolved with extra antibiotics and NSAID and sodium chloride drops. Bilateral iritis and unilateral iritis was also noticed, but again, it resolved quite quickly. Iris prolapse was noticed in 1 patient where we had to reposition and suture the wound. It was noticed in manual SICS. So we did a comparison with all the previous studies that had did the immediate sequential bilateral cataract surgery, and it was comparative in terms of the outcomes of endophthalmitis, posterior capsular rupture, and retinal detachment. We did not have any end-off or any retinal detachment in our patients. So overall, there were no sight-threatening complications. We did not have anything related to end-off because of the stringent intraoperative protocols. But we did notice that 30 eyes had a spherical equivalent greater than plus or minus 0.75, but we did not do any toric implantation, and the 11 of the eyes we did were manual SICS, so we couldn't really factor in that aspect. So pre-op astigmatism was not addressed in this study. And comparative again with the spherical equivalent, what we noticed was with the other studies comparing, ours was also of an equal outcome. So more or less 99% achieved less than plus or minus 1 diopter spherical equivalent. So it is easy to achieve target refraction if we have a good validation guideline. And this was one of the 6 largest study done globally. And first to compare manual SICS with phacoemulsification. So as I told initially, if we consider each eye as an individual and autonomous eye, it's going to be safe in terms of infective outcomes. Thank you.
Very, very nice. Thank you. Next speaker is Dr. Khaled Moghib. Is he here? No? Okay. Next is Dr. Norris Gikin Mustafa. Dr. Mustafa? Nope. Okay. Harvey's next. Many no-shows. Touring the Taj Mahal. Okay. Hi, Dr. Harvey Uy here. On the Lensar laser system. Congratulations on your award.
Thank you. So good afternoon, everyone, and it's my pleasure to be here to talk about this technology. I want to say that we received a research grant from Lensar. And believe it or not, femtosecond laser-assisted cataract surgery has been around for more than a decade, and the technology keeps on improving to improve both the patient and surgeon experience. And unlike the capsulase, for example, which just does anterior capsulotomy, this technology will also soften your lens, create your corneal incisions, make arcuate incisions to decrease your astigmatism, as well as guide toric IOL placements. And with this new machine called the Lensar Ally system, there are some additional advantages compared to the older system. First of all, you have a more secure and easier docking of the patients. There are now multiple cameras that scan the anterior segment so that you're able to reconstruct the anterior segment anatomy more quickly. The software and hardware are better, so you can calculate the treatment plan more quickly, and the laser fires more quickly, so you can get everything done basically a lot more quickly. And amazingly, they're able to pack these additional features into a smaller footprint, so it occupies less space in the OR and gives you maximal flexibility with patient positioning. So if you have a small OR, this is of great advantage. And over the next few minutes, we'll be talking about our early clinical outcomes using this new Lensar Ally system. So this is a single-center study done at the Peregrine Eye and Laser Institute in the Philippines. We had 4 surgeons doing the surgeries. All patients received an Alcon SA60 lens, and we enrolled 67 eyes. They're really standard inclusion and exclusion criteria for a cataract study. Patients were followed up day 1, week 2, and week 6. So uniformly, all of the surgeons agree that the new Ally system greatly enhances your ability to dock the patient with ease. It's only a few patients, particularly if they have very small eyes, where there might be some difficulty docking these patients. But none of these patients experience blackout during the docking, and everybody loves the new system because it's just easier. The corneal incisions are also much better, and we find that in many cases we don't need any additional instruments. We can open up those side ports and clear corneal incisions, sometimes with just the cannula of your OVD, sometimes with a Sinski instrument. Of course, all of the capsules are free-floating, and we successfully completed the laser procedure in all patients. In the Philippines, cataracts tend to be a little bit harder than in the West, so the mean nucleus grading in this group of patients was 3.4. But you can see on the other end, we actually had patients with black cataracts. And in our practice, basically, we do these flax procedures in two groups: patients who want just the best of everything, and patients who are just the worst of everything. Complicated cataract surgery is where we find that the laser helps us do the surgery more easily. In this group, the overall effective phaco time was 10.9, which is pretty decent. Visual outcomes were amazing. The mean corrected distance visual acuity was 0.06. This is 2020 basically. And all of the patients had at least 20/40 or better corrected distance visual acuity. Again, because the laser softens the lens, you need less phaco energy and fluid to perform the surgery. So we have very few patients with corneal edema, and those who have had minimal corneal edema, the surgery is very safe, no adverse events. And we find that using this technology, we're able to shorten our cycle time by about 9 minutes. So because you're able to do the surgery more quickly, you can put more patients in the operating room, and that makes you more productive. So again, with the new LENSAR Ally system, the advantages are better suction, easier docking, shorter imaging time, and faster laser speed. You virtually don't have to use your knives anymore. It's very rare that you're going to need knives. Very consistent in creating the capsulotomy. And because of all of these advantages, the post-operative visual outcomes and corneal edema are generally better than you would expect if you do conventional surgery. So we find that this LENSAR Ally system effectively and safely facilitates cataract surgery while improving workflow time and efficiency. Thank you very much for your kind attention.
Very nice. So it's a combined phaco with femto, combined, not yet.
It's not yet. You can just do the laser part, but there are plans to
integrate,
combine it with the cataract surgery. So that'll even save you more time.
More time, yes. Okay. Next speaker, Dr. Dana Abdulina. Hello, ma'am. Please.
Good afternoon, everyone. My name is Dana. It's a big honor to be here. I'm from Kazakhstan. So as you can see, it's our Kazakh Eye Research Institute. So my presentation is about intraocular toric lens, non-conflicting interests. Okay, introduction. So how do you, as you know, congenital cataract is the pathological condition characterized by clouding of the eye lens and abnormal changes in its shapes and the size presents at birth. In Asia, it's 4.24 per 10,000, while in Kazakhstan it's approximately 1.6 to 1.8 per 10,000. According to various researchers, CC accounts for 10% to the 20% of cases of visual impairment leading to disability. Also, intraocular lenses implantation in widely used in the treatment of CC. Residual astigmatism remains a barrier to the complete restoration of visual acuity. Torical IOLs have been proposed as solution for correcting residual astigmatism. However, there is limited data regarding the use of toric lenses in the CC cases. To evaluate visual and refractive outcomes following toric IOLs implantation in children with congenital cataract and astigmatism. Materials and the methods study in settings. This case control study includes 37 eyes, which means 37 children who underwent lens aspiration with IOL implantation. It was in June 2021 and December 2022 in our country. And we have two groups of 19 eyes in one group. We used monofocal non-toric lens, and 18 eyes and they received monofocal toric IOLs. What about criteria? Inclusion criteria, visually signifying, CC, corneal astigmatism less than 1.75 diopters, and the age older than 6 years. Exclusion criteria, corneal diameter less than 9 mm, corneal scarring, irregular astigmatism, intraocular pressure less than 25, active uveitis and the history of uveitis, traumatic sublux and other types of cataract, persistent fetal vasculate, and disease of macula or optic nerve, previous intraocular surgery. Results, corneal astigmatism, as you can see when comparing the two groups at each time point to statistically significant differences were observed. As you can see, a diagram of post-operation of astigmatism in toric group, it decreased from 2.84 to the 0.53 in 6 months. Also, non-toric group decreased only from 3.05 to 2.33. Both groups showed a decrease in astigmatism, but after 6 months, toric IOLs still have better results. At the final follow-up, CDVA of 20/25 or better was achieved in 67% and 0% of eyes in the toric and the non-toric groups respectively. CDVA of 20/40 or better was achieved in 100% and 47% of eyes in the toric and the non-toric groups respectively. Oh, sorry. Okay, our results was compared to similar research and demonstrated closely results. And conclusion, the results of our study demonstrated that cataract surgery with toric IOL implantation compared to non-toric IOL implantation, while reviewable results in correcting pre-existing corneal astigmatism and improving of distance and near visual acuity in children. Thank you for your attention, and it's our colleagues from my country. Thank you.
Feng Bin Lin, I think she's not here, the last speaker. Okay, that ends our talk because we're over time. Thank you very much, everybody.